Welcome to the AOSpine Clinical Experts Advice Forum webinars, the second in the series on incidental lumbar durotomies. As all of us know, AOSpine is not only the largest spine society in the world, it is quite well known for knowledge creation and not just for knowledge propagation. Now, towards this end, we have two arms of work. We have the AOSpine Knowledge Forums, which work under the 5 knowledge forums categories of tumor, deformity, spinal cord injury, trauma, and degenerative. And these forums are really working on knowledge creation where there is randomized clinical trials and evidence-based medicine which is possible. But we all know from our practice there are many clinical situations where the practicing surgeon faces situations where a randomized clinical trial is not possible. And at that periods, we are all looking for what will an expert do, and is it possible for me to distill his experience so that I can benefit richly from this. And so that is the basis of the clinical expert advice forums. And they are dealing with clinical situations like intraoperative vertebral artery lacerations, pedicle screws that are dangerously positioned but asymptomatic. And you can see on the slide 6 such topics which we have taken in the first round of the forums. A couple of weeks before, we had the first webinar on the intraoperative vertebral artery laceration. And today, we have the accidental tears in the dura mater that result in leakage of cerebral spinal fluid. Now, this is a situation which none of us like to have, but frequently face it. We frequently have intraoperative tears, and then we see the fluid leaking and sometimes the nerve roots and the neural elements popping out, or we miss that during the actual surgery, and then later in the follow-up we see a large leak, and then it becomes a challenge in management. Now, this is a very interesting topic, and here we have a wide range of excellent pioneering surgeons, experts from all over the world. And I would like to start off from thanking Asdrubal, who is the lead author of today's forum. Now, you can see on the slide everything written about Asdrubal, but I wouldn't like to discredit by reading through this because everybody in and out of AOSpine knows Asdrubal. He is also the chair-elect of the International AOSpine. And Asdrubal, congratulations for this. And I am sure that AOSpine is going to have a very good, wonderful 3 years under your leadership starting. Along with Asdrubal, we also have a very good team who is going to discuss all the nuances today. So we have Bastian, we have Michael, Avelino, Nestor, Jason, Karsten, Yoshi, and Andre. And I'm sure that we cannot get a group which is more expert in this field than we have what we have today. So welcome to the faculty and welcome to all of you across the world. And without wasting time, we would go on to the first discussion. And I would like to invite Asdrubal to first talk on what is the impact of this complication and what is its morbidity and what is the health cost. Asdrubal, please.
Congratulations, Raja, for the idea to build the expert forums. We know that incidental durotomy has a high impact on morbidity and health cost, and we need to have a worldwide opinion for prompt diagnosis and effective treatment. It's a common and challenging complications. The incidence ranged up to 70%. Several impacts happen when durotomy is observed. Some patients is more propense to durotomy than others. Here we see all the impact of incidental durotomy, like infection, pseudomeningocele, radiculopathy, caudal displacement of intracranial content, leading to subdural hematoma, lower patient satisfaction, longer hospital length of stay, need for revision, and both increase the hospitalization cost and legal implications. Medical malpractice from incidental durotomy was observed in 48 cases. In half of them, the ruling was in favor of defending physician. The main reason of claims was delay in diagnosis or treatment, 43%, improper durotomy repair. If you learn everything from this webinar, we'll save around $2,057,298. So you need to learn everything about incidental durotomy. And you need to be very aware about legal implication, the way that we need to avoid the legal implication. The best way to prevent is to have everything on the informed consent, early recognition, proper durotomy repair, and timely operation. The patients at risk are the case of revision surgery, spinal stenosis, synovial cyst, and sometimes the durotomy can be observed after surgery caused by pedicle screw insertion. The repair precludes the recognition of the durotor. So we need to have early recognition in order to have the treatment, and different options of the treatment are possible, from suturing to bed rest. So the take-home message is that in this situation, there is little evidence in the literature. The patient has high expectation, and the surgeon's experience is the main and the only option. So at the end, prompt recognition and meticulous repair are the solutions. So in order to go ahead, I think that Yoshi, could you start your presentation, Yoshi?
Yeah, thank you, Asuruba. Hello, everyone. My name is Yoshi Kawaguchi. Okay, today I will show you the 3 videos. We'll show the incidental durotomy during posterior lumbar surgery. These videos clearly show the moment when it happens. Video courtesy of Dr. Toshiyuki Takahashi, Spinal Disorder Center, Fujieda Heisei Memorial Hospital in Japan. This is a case of a 73-year-old male with L5 ischemic spondylolisthesis. The doctor is making penetration of L5 using high-speed bar. The tip of the bar is steel. Upper is medial. Lower is lateral. You can see the incidental durotomy, and cardiac line is coming, and the legal discharge is coming. What will you do? Don't get upset. That is very important. The doctor will confirm the hole, and the hole is very small, and fortunately the doctor can suture the hole. That is frequently happen. There are 2 types of the tip of the bar: steel bar and diamond bar. Steel tip is dangerous and potential direct injury, so it's very careful. So diamond tip is relatively safe, but heat injury might occur. This is a case 77-year-old female with L4-5 degenerative spondylolisthesis. You must be aware that longo for spinal listhesis is very dangerous. When the surgeon uses longo, okay, the longo, the weak grip is okay, but tight grip make durotomy, incidental durotomy. In this case, when the ligamental flavum removed with the tight grip, this now you can see nerve root and leakage is coming. It is very, very dangerous. This is another case. 63-year-old man with lumbar canal stenosis, decompression, multiple mobility back case. So longo for reoperation is very dangerous. Please watch the video very carefully. When the surgeon tries to remove the yellow ligament, you can see instant durotomy occur and the nerve is coming. What will you do? Don't get upset. That is very important. The surgeon try to make a bigger hole and try to insert the cauda equina into the dura. However, it is very difficult because the hole is very small. So the surgeon tried to make a bigger hole with the diamond bar and cut the dura mater again and try to insert cauda equina into the dura. Try to clip. However, this case, it is very dangerous. It is impossible. So the surgeon tried to use artificial dura mater. So this is a case, a 60-year-old man, L4-5 degenerative spondylolisthesis. You can see malposition of the pedicle screw, like this scheme right side. The surgeon tried to remove the pedicle screw and tried to remove the small bone tip. So the surgeon confirmed the small hole around the nerve root. You can see the small hole and the nerve filament from the nerve root. So the surgeon tried to confirm the hole. So fortunately, the hole is small, so they can suture the hole. The surgeon tried to suture with the 6-0 nylon blade. Fortunately, this is a very small hole, so he used the polyethylene glycol and fibrin glue is packing and fat graft is used. And feeding degree again, and bigger fat graft to put. Okay, thank you. So please, my take-home message is number one, avoid dangerous procedures during surgery. Number two, be careful when using steel bar and longeau. Number three, insert pedicle screw in appropriate position. Thank you for your attention.
Thank you, Yoshi. That was really good, and a lot of take-home messages on that. I saw that you were using titanium clips in one of the cases. I mean, wherever both can be used, what is your preference? Do you like to suture or would you use titanium clips?
Yeah, my primary.
Do you find any difference between?
Try to suture with the nylon, 60 nylon. So that is a very rare case using the clip. So usually I will suture with the nylon.
All right. Okay. Good.
Thank you.
Now we will go on to another. Yeah. Thank you, Yoshi, for those wonderful videos. So we'll now go on to another scenario. So lateral and anterior approaches are becoming very, very common. They are becoming the preferred approaches for many spine surgeons to restore sagittal alignment and to get a good anterior fixation. And incidental lumbar durotomies in this situation is sometimes frequent, especially when you're starting this experience. And I would like to invite Dr. Nestor Tabada, a very prominent surgeon from Colombia, to talk about this interesting problem. Nestor, please.
Thank you, Raya. Thank you, Adrual, for the opportunity to be here. Hello, everybody. This is a typical clinical case. This is a woman, 71 years old, hypertension, and she had a lumbar vein for 7 years and the claudication in the last 3 years, and the radiculopathy in the right leg for 1 year. The osvestry showed the impairment in the quality of life. This is the image of the CT scan and the panoramic X-ray, and in the MRI you can see the scoliosis de novo and sagittal balance and the multifactorial lumbar stenosis L2S1. The surgery in this case was at the A-leaf F5-1 and psoas approach L2, L5 in the single position surgery. Here you can see the incision for the first step, the 5-1. You can see here the presacral veins at the middle line reference in this case in the space in L5, F1. And then the disc exposure is similar to the anterior cervical discectomy. You can see here in the right the space of the discectomy in the L5 S1. And when the anterior common ligament and some osteophyte resecate, abundant liquid is evident in this moment. In these cases, in the anterior lumbar approach, it's not possible to repair, direct repair of the dura madre. In this case, in the A-leaf, we can perform direct or indirect decompression. However, in the transpsoas or prepsoas lateral approach, the decompression is only indirect, and we don't visualize the dura. So we don't know the point of the incidental durotomy, except if you have endoscopic in this moment in the surgery. Nevertheless, we have tips and tricks in incidental durotomy in the anterior approach. The first step, you must finish the discectomy. In the case of the A-leaf, and apply biological fibrin glue near of the dural sac, and then you can the position of the case cover by fibrillar hemostatic, which help to contain the fistula and reabsorb at 2 weeks without interfering with the fusion. In the lateral approach, X-leaf or O-leaf, how can we not see the dura? At the end of the discectomy, it is suggested to introduce the case cover by the fibrillar hemostatic. Here you can see the case of A-leaf cover, in this case is a surgicel, and the lateral case cover of the surgicel. The hemostatic will be absorbed in 14 days and does interfere with the fusion. And in the image, you can see the solution, the A-leaf 5-1 and 2 for A-leaf, lateral A-leaf, and O-leaf in 2, 3, 3, 4, and 4, and 4, 5. In our service, we perform 150 anterior and lateral approach per year, and 3 incidental durotomy have been present in the last 10 years. We suggest bed rest only 24 hours. It was not necessary to review any of the 3 cases in our experience. Of our initial case, after the incidental durotomy, the deambulation began the next day, and she did not present symptoms of dural tears. And in conclusion, the incidental durotomy in anterior lumbar approach has a very low incidence. Direct in this space, and the fibrillar hemostatic cover the cage are the grays used in the anterior and lateral approach. Thank you.
So the most frequent and dangerous complications in the anterior and lateral approaches, we can say that they are not durotomies. They are usually visceral and vascular complications. So dural tears and CSF leaks are no common in these approaches. So in recent reviews, for example, in one of the British Journal of Neurosurgery, the incidence of dural tear in A-leaf was only 1 case in a total of 241 cases done in 5 different series. However, there are some publications like the famous book by Alex Ducker about the spinal surgery, a review of techniques. The incidence can be as high as 10% in some series. So surgeons, we must be aware and know how to solve them. In lateral transverse approaches or pre-psoas, also the probability of having a dural tear is very low. But in some cases, it can be cumbersome. For example, in the thoracic spine, we are doing more and more lateral approaches. And for example, in the thoracic spine, a dural tear, if it's not well repaired, it can cause CSF collection in the pulmonary cavity, and this can be a serious problem. And in many cases, you need reintervention. There's a recent paper published by the HSS from New York group in which they show how they conveniently solve that problem by putting a subarachnoid drain and a thoracic drain. I said that usually anterior complications are not durotomies, as Nestor has already shown. And most frequent complications are visceral and vascular.
Thank you. Can I request Michael Wang to sum up and give his take-home messages, please, on this approach?
Okay, great. So this is really an interesting point, because what we're seeing here is a new technology, which is the lateral approach, and of course the anterior approach is already being used. But when you look at this type of problem, this is a very difficult case, and I think that the surgeons here handled it very well. This is a very, very interesting area where we have to find new techniques to close the dura, and I think that one of the values of the AO webinars is to be able to see how people are doing this and managing the new complications that we have arrived at. So Yoshi showed some very nice posterior standard approaches how you can sew up the dura, and now you're going to see, like in this last case, some more interesting and different novel ways of trying to handle this type of problem. So thank you for sharing that. Great. I think I'm up next. I'm going to be talking about pure endoscopic surgery. This is an area where there's been a lot of development in recent times. Yes? Okay, great. So you want to just run the video for us, because the video will basically tell it all. So this concept of doing pure endoscopic surgery is sort of a new area in America, but I know that in Asia in particular and in Germany this has been very popular. So this shows a case of an interlaminar approach, and this type of interlaminar approach is being used with a slightly larger working channel. This is called a delta system. It's a 1 centimeter diameter, so it's a little bit bigger than the standard interlaminar method. And here you can see we're doing a case of very tight stenosis, and we're drilling and removing bone in the lamina, and then later on in the ligament. And this is a totally different type of setting. If you've never used this technology, the reality is that you only really get one working portal, right? So in other words, you don't get to use two different sets of instruments. At any one time, you only have the one instrument. So we have to switch, for example, you can see there between drilling to thin out the lamina, and now we're going to use the kerosene and to try to take the remainder of the bone. So you can see us going back and forth, and we speed up a little bit here just for the sake of showing you how we're doing this. So in reality, it should happen just like a standard open or mini open type of surgery. So the surgery proceeds, and this is a case where there's very tight stenosis, and we arrive at an area where there is no ligamentum. And here you can see, this is a very interesting point. We've become so reliant on using the irrigation pressure to keep the dura away from us that here we inadvertently bite the dura right there. There you can see it right there. Not only do we bite the dura, there's actually a neural injury. You can see that some of the nerve, which in essence wasn't clinically relevant, but was actually lacerated by that. So this is a very, very stressful situation, as you can imagine, because you cannot simply go in and sew this up. So I'll be curious to see how the panelists feel about this. Should you convert this surgery to open? Should you simply make an incision and open things up and then do an open laminectomy? And what you can see is that, you know, here you have got to keep your cool. It's just like Yoshi said, the worst thing you can do is freak out and just stop doing the surgery. You still have to do the decompression. So now we're forced to sort of try to work around this, and this is very, very aggravating. We're now starting to work our decompression here. You can see we've rotated the endoscope to look laterally. And if you haven't done these surgeries, it is a little bit disorienting. And now we're going to continue all of that with those rootlets sort of in your way. Again, there's no way to sort of push this stuff out of the way actively. Even if you put a cottonoid or a patty or a pledget there, every time you put an instrument in or out, they're fitted almost exactly to the bore size, so you'll pull your cottonoid in and out and in and out. So it's actually a little bit difficult to handle this, but you have to keep your cool. And we're going to go laterally, then we're going to go and do the cranial and caudal decompression. So we're trying to finish, if you will, the laminar decompression here despite the presence of those rootlets. And in this particular case, as is mentioned in the video, I believe that a major culprit was the loss of the irrigation pressure. At one point, we had done this case at night, at one point the whole irrigation had run out, and so there was no positive pressure depressing upon the dura. And so we're going to finish that out. And then the question arises, you know, how do you really repair this? And I think this is a point of discussion, which is when you're doing the very small approaches, whether it be using a 14 millimeter tube or a 16 millimeter tube, or in this case, a 10 millimeter tube, do you need to primarily repair this? Do you need to sew this back up? Or can you simply rely on the soft tissue not being so disrupted to prevent you from having a pseudomeningocele or a sort of a permanent CSF leak, right? So in this particular case, what we decided is we're gonna put down Duragen, which is like a collagen matrix. And I think we're going to see some interesting discussion later on about how to patch the dura. We already saw some from Yoshi, and place that and then use a fibrin glue to back that up and rely on the soft tissue to sort of envelop the area. So that's a case of one of my complications, a horrific type of complication, which unfortunately is caught on video there. So welcome to discussion and comments. And again, Astrobal, thank you to you and Raja for putting this together.
Very clear show complication and how not to lose your cool. So can I ask anybody else from the faculty to express their opinion on whether they would suture such small tears. And can I ask Yoshi to give his opinion on this?
Thank you, Raja. So, Michael, I have a question. Can you repair the durotomy, the area of the incident durotomy? Can you repair it using a small hole?
Yoshi?
So I'm sorry, with existing technology, the only technology I'm aware of that might work is a nitinol clip, that is a self-closing clip that you may be able to fit through the endoscope. The problem is that I think even that is too big, the current standard, to fit through most of these endoscopes. And the second part is you showed that beautiful video that I don't know where you got these videos from, probably from your colleagues. They're so interesting because usually we can push the nerve roots away then sew, right? But in endoscopy, you cannot push the nerve roots away and clip or sew because you can only put one instrument through. So this is a very interesting area of exploration. Maybe you can put a barrier first to kind of keep the nerve roots away, then clip it. But again, this is an area I think maybe the Japanese are going to find a solution to, or maybe the Koreans or Chinese, because you guys do so much more endoscopy.
How about using a polyethylene glycol sheet?
Polyethylene glycol sheet, yeah. So in this case, we used a collagen sheet and fibrin glue, right? But of course, that's not really. Somehow you have to mechanically sew it too, is the idea, right? And that's the hard part, right? Maybe you could put a sheet down, then staple it in place over everything. And I am aware that there are some new glues being developed, I think by Baxter, where you can actually put a sheet, and it's never been done. Like you put a glue, then a sheet. I don't know if you can do that through an endoscope, though. Everything's hard through the endoscope, right?
I always use polyethylene glycol sheet and fibrin glue.
Okay. So there are some other questions for Michael and Yoshi. So when would you not or think of repairing a dural tear? I mean, this is one of the commonest things in the mind of surgeons who are beginning their career. Which are all the dural tears that you can leave without a suture?
I think Raj, I think it's a great question. I think the question really is one of future prediction. You know, you could imagine that, and we're going to hear later about lumbar drains, I think, and other techniques that you can also use as adjuncts, positioning, how long you keep the patient in bed, you put a drain, you not put a drain. I think the reality is every time we encounter this, we don't know what's going to happen, right? So you're making a statistical prediction, and some people err on the side of being more aggressive to stop the CSF leak. Some people are on the more nihilistic side, and you hear a lot of people say, well, MIS surgery, they just sent the patient home the next day and everything was fine. And the reality is that that's really not always the case. I mean, the reality is that there are going to be cases where you didn't repair the dura, that it was okay, and there are going to be cases where you didn't repair the dura and you're going back to surgery later, right? And I think that ultimately the surgeon's philosophy plays the big part, because if you can repair it, we always try to do that, right? If you can do it, in this particular case, the question was, were we willing to convert this surgery to an open operation in order to achieve that? And in that case, we did not. But, you know, that doesn't always work.
I agree with Michael.
So, Michael, we always...
So lumbar drainage is very effective, especially when we legal discharge from the cervical and thoracic spine. Sometimes from the cases with OPLL, we always use lumbar drainage.
So, Michael, we always hear of this term watertight closure. So, you know, many of the neurosurgeons talk of, okay, if you have a pinhole dural tear, then it's important to repair it. But if you have a bigger dural tear, then, you know, it's not a valvular mechanism. The CSF will look after itself. Just do a watertight closure. So, how much do you believe in this term watertight closure? Does it work, or?
So, you know, I don't know if that's really true, because it depends on how much pressure there is, right? And then it depends on healing. Ultimately, it's a race of healing, right? The healing has to happen. But I think, Roger, you bring up a very important point, maybe for some of the younger surgeons, they're not aware that the small tears are the really bad ones. The giant tears, when you're doing an open surgery, somehow those people end up healing, whether it's the inflammatory reaction. I see Yoshi nodding his head. I'll let him make a comment in a second. Blood in the area, whatever. It's the lumbar microdiscectomies that are so annoying. Those are the ones that really come back again and again, and really, I learned that the hard way, really.
So there's another question on, do you think use of bone scalpels instead of diamond burrs? Diamond burrs pick up a lot of heat and they can cause a thermal injury to the dura. So what do you think of bone scalpels and all these ultrasound instruments which are supposed to cause less injury to the dura? What's your experience, Michael and Yoshi?
Yes, I sometimes use ultrasound instrument for especially for cutting LBLL. That is very effective. However, it is not so. The speed is very small, very low. So I prefer to use a diamond bar usually.
Yeah, that's Raja. People talk about that with the harmonics, right? Being less mechanical and less disruptive and having lower dural tear rates. The group at Johns Hopkins, I think it was Mohammed Biden or his brother, one of them had published this paper showing that they got a lot of dural tears. I think the take home was that if there's scar tissue formation, the harmonics still lead to potential for dural rupture, but in clean cases, maybe it's lower. That is certainly a common claim, and I wouldn't say they're wrong. I just think that you can cut the dura with almost anything if you really try hard enough, right?
Yeah. Okay. All right. Thanks a lot, Michael, and thank you, Yoshi. And now we'll go on to another important area where we frequently have a problem, and that's mistilif. And to discuss this important topic, we have Bastian.
Yeah, thank you. Thank you for the invitation. In MIS, okay, sorry. In MIS TLIF, there's a lot of literature, and we see that there's no difference between MIS versus open in durotomy, and that's no impact of a microscope as well. We use it every time, nearly. In a study from Freiburg, we see 6.2% in MIS TLIF, but it's about the cases, and if you see, it's 8.6% of the operated patient. That means you can mix your cases as well. So what is the type of decompression is the key. That means sometimes we see, like we saw before in screw positioning, dural leakage, but that's really seldom. So it depends on the decompression you do, and in an MIS TLIF you can do different techniques. So here's a painted picture, and you can do the decompression laterally so that you take out the outer part of the facet and leave the inner part so you only see the root. Or you can do the inner part and decompress over the top, for example, or you can do a facetectomy and the inner part, or you can go by the midline in MIS TLIF. It depends. And so that's where you do your cage in as well. Do you do it from lateral by resecting the facet, or do you do it medially, your TLIF? Then you have a higher incidence of durotomy in our suspicion. And if you look at this case, for example, here I have some examples. You have a case with an intact arachnoidea and a scar tissue of the dura. We have a great defect, and that's all the medial aspect of the dura. And here you have adhesions on the facet. And of course, like we heard before, in this case we had dural leakage as well. It was a pseudoarthrosis in TLIF or in PLIF insertion, and we removed the cage and did a new TLIF from medially. But this is, as we know before. So awareness is the key, and risk factors are the anatomical variations, as we heard before, past operations, facet cysts, spondylolisthesis, obesity as well, and of course multi-segmental disease. Some studies also showed older age. Here are some studies which see that. So, dangerous moments in the literature and in our experience are decompression, of course, scar tissue removal, cage insertion, and sometimes preparation of the lamina in lytic situation or in congenital situation, because you have anomalies in the lamina. So you can do dural laceration, also you are not in the spinal channel. And dangerous instrument, especially in revision, is the dissector. You see a case later where there was a dural leakage because of a dissector in scar tissue. Kerrison rongeur, of course. The drill, as we saw before, there's sharp drills and diamond burrs, which are better. Curette can be a problem as well. And of course, in MIS TLIF, the cage insertions, so always protect the dura. So in our opinion, sometimes sharp and controlled is better than blunt and uncontrolled. Sometimes bigger instruments can be safer because they are not so pointy. And of course, do not use too much force in preparation. Some scar tissue can be left when it does not compress and when you have a good decompression. Be aware in congenital situation, and of course protect the dura while inserting the cage. The therapeutic strategies depend on the kind of decompression, as I showed before. If you come from far lateral, patching with Tachosil is often enough, because you can't see really the dura leakage, or it's only at the root. If you come inside the spinal channel, you have to do a step-by-step solution, like I show here. First, you have to avoid further CSF loss with the right positioning of the patient, and for example, with cozy pads. Then you have to take off the pressure. You have to do a further decompression, and you have to see the whole defect. Put back the fibers if needed, that we saw before as well. If possible, try to stitch the leak. We used Polene as well, 6.0, but now we use Gore-Tex suturing. Then do a patch on top. We use Tachosil normally. Sometimes we use a sandwich technique. That means we do a Tachosil inside the leakage and do the yellow side on the top, and then take a Tachosil the other way around from the outside. So if you have the pressure that puts the Tachosil against the dura. Check your plastic with a Valsalva maneuver by increasing the ventilation pressure. We put it up to 40 centimeter. And if needed, do a muzzle flap or a fat patch. There's a really nice paper of the Hamburg group around Papavero and Kote. They have incidental durotomy, first 8 and 10 steps, and I really recommend this paper. Here we have this case I talked about, and here you have the video. It's in scar tissue, and unfortunately this was at the end of the suturing, but we have a Prolene here, and if possible we have a watertight suturing. And you see it's really well decompressed. It's in the midline of the decompression defect. And now we do a patching with Tachosil in this case. Sometimes if there are big defects, we use Luoblunt onlay. That's a bovine pericardium with a fascia, and which holds really good. And we have no revision surgery for that up to now. We use it since 1 year. But I only use it in great defects. Otherwise, we do it like that with a patch. Thank you very much. We can turn on to the video. Okay, and the extended therapeutic strategies are CSF drain. Our strategy is 3 days, then reduce this.
Thank you.
Okay.
All right. Thank you, Bastian. Before we go on to Astrubal, who will also discuss about the same topic, there are two questions for you. What will you do if the dural tear is more anterior?
That depends. Normally, I would take a dura patch, let's say Tahosil or Leoblant, around the dura, try to get it around. In extreme cases, you can open the dura from dorsally and go to anteriorly, but that's pretty annoying sometimes.
Do you have a change of your post-operative regime in these patients who had a CSF leak?
We don't know. I wrote this at the end. We do bed rest for 48 hours, 24 hours flat, and 24 hours 30 degrees.
Okay. Thank you, Bastian. We'll now go on to Astrubal. Astrubal, please.
Okay, thank you. As you know, MIS leaf is I widely accept MIS fusion, and I'm gonna touch how to avoid CSF leakage during the compression and cage placement. I usually do extraforaminal lumbar interbody fusion. By doing that, I move away from the dura to a more lateral entrance point located in the junction between the transverse process and the superior facet. This makes me faster access to the intervertebral disc with just removal of the superior facet. So we need just remove the superior facet, and then we are directly at the intervertebral disc. The nerve root is not visualized, but a gentle manipulation cranially along with the soft tissue and fats allows to unrestricted view of the intervertebral and the hernia disc. One another thing that I want to highlight is the stepwise resection of the lumbar facet during the compression is according to the specific needs of proximal nerve root decompression and the spinal canal decompression. And always during those decompression, the dura mater is protected by the yellow ligament. So I totally agree with Bastian. This far lateral approach, we stay away from the dura, and we are also protected by the yellow ligament. So here I show just the exit route, the nerve crossing, and just to showing some decompression and the cage placement without see any dura, just yellow ligament. So we have a huge and a great barrier against CSF leakage.
Yoshi, do you have some take-home message and some helpful tips?
Yeah. I think the incidentally is frequently occur in the multiple operated back case, the reoperation case. So the reoperation is very difficult and very dangerous. So if you remove the bone and the ligament, so you must release from the dura between the dura and the soft tissue. You must remove it very carefully. That is my take-home message.
Okay. Thank you, Yoshi. We now go on to the next presentation by Michael.
I think this, we don't have a case for this. I think this is an extra slide they put in.
All right. So what would you like to say? I mean, some helpful tips?
Yeah, I think we covered this in one of the earlier cases in terms of the difficulty with how we do this. You know, this is one of those things where it's basically Fortunately, these are relatively uncommon injuries. We're seeing them more and more as people are coming lateral and oblique with OLIF and then, of course, with ALIF. But since the approach is so small, we rarely see this, which is fortunate because these are very difficult, if not almost impossible to repair. And I think almost nobody has a video of this because we rarely use the microscope or endoscope for this type of approach unless you intentionally have an injury. Or I shouldn't say that. Nobody would have an intentional injury unless you intentionally were trying to record and then you had an injury on top of that. So we could move forward, Raja, in the interest of time.
Bastian and Nestor, do you have anything more to add on this?
No, that's, I totally agree. You seldom have a microscope, so you don't use the camera. And it's really, really seldom, as most of the times you leave the ligament intact or the annulus to the dura. So,
with Bastian, it's important the integration of the ligament yellow. I'm totally agree with Bastian.
Okay, good. So we'll now go on to Ander, who will speak on dural sealants, types, uses, and cautions.
Okay, perfect. So, so far so good. We will discuss a little bit about the different dural sealants, types, uses, and warnings. So there is a wide range of possibilities in the market. So to facilitate the discussion, I divided them into 4 groups regarding their main components. So we have the ones that are derived from thrombin and fibrogen. They were initially used to be hemostatic, so to be used in cardiovascular and general surgery. We have the glues that are tissue and Evisel. Bastian told us a little bit about the Tacozil, which is a patch, but also in the basis of thrombin and fibrogen. Also, as a glue, we have a glutaraldehyde plus bovine albumin based, that is bioglue, designed also initially to be used in cardiovascular and general surgery, but mainly in cardiovascular surgery. So in another group, we have the polyethylene glycol, also mentioned by Yoshi, the PEG. It can be used as a hydrogel. We have a Duracell Exact, and also a Derus. And we also have the patch, which is tissue patch. And finally, we have the collagen matrix, also mentioned by Bastian. We have Duragen, which is a bovine extract, and we have also Tissidura, which is equine extract. They basically form a scaffold for the fibroblast to proliferate into and form a barrier of impermeabilization of the dura. So I will try to highlight a little bit some particularities of these agents. In the hemostatic group, we have to keep in mind that none of them are FDA approved for neurosurgery, so they are all designed to be for cardiovascular or general surgery. We must understand that the ones that have bovine protein in their basis, especially tissue that has a protein, they can lead to allergic reactions and also anaphylactic shock, so we have to remember that. All the ones that are human plasma derived can lead to virus, can be virus transmitters. There is no case in the literature recorded, but we have to keep that in mind. So we have something called burst pressure, that is the pressure, the intradural pressure that leads to a leakage in the sealant that disrupts the sealant. So with tissue, we have the lowest burst pressure, and we have a high burst pressure with Tacozil, and BioGlue has an intermediate burst pressure. But we have to remember that the fabricant tells us that it can be cytotoxic, especially neurotoxic, so we have to be careful when using them. So in the PEG group, they are FDA approved for using in neurosurgery. They have high burst pressure, They rapidly adhere to the dura, so it's very interesting, their use. When we use Duracell and Duracell Exact, also Aderus, they have a flashy color, so we can see easily the covering of the defect, so we can manage to understand where we are putting the sealant. We also have a patch of PEG, which is tissue patch. Baxter also developed one. It's called Hemo patch, which is also PEG based. So in the collagen matrix, they are used as a duro substitute. We don't have to suture most of them; just put it in, and they conform to the complex surface of the dura. They're also they have also a high burst pressure, so they're very interesting to be used. But as a patch, they don't fit everywhere, every defect. So sometimes the glues are more easy to fit. So another thing important to remember, I didn't say that with the PEGs, the polyethylene glycol, they can swell. So they can swell up to 40%. So in confined places, we have to be careful to use them, as they can lead to compression in the nerve root or the dura. So we have to be. There are some cases reports in the literature, so it's important to keep that in mind. So what about cost? In my city, Belo Horizonte, in Brazil, Duracell can be 5 times more expensive than Duracell, and almost 3 times more expensive than tissue. So they can lead to a higher cost in surgery. So whenever possible, and this is as a take-home message, we have to suture. So whenever possible, suture the lesion. We have to be aware of the counterindications and downsides of each product, the bovine protein allergy, the swelling of Duracell, the virus infection, and also the neurotoxicity of BioGlue. So that will be it. Thank you.
Thank you, Castilhos. We're going to move to Karsten. Karsten is going to talk about CSF leakage without being noticed during intraoperative incidental durotomy. Please, Karsten, go ahead.
The occult tears are actually quite scarce in the literature. You find a few papers, but the incidence is rather low. It's below 1%. And so you don't find a lot about this, but you find these patients ending up in your clinic every now and then. Now, why are these cases unnoticed? One thing is incomplete visualization, because of bleeding, because of incomplete decompression, or because of some other technical issues. But the majority, at least from my experience, is that they're just not present during surgery and end up only in the postoperative period. Now, what is the clinical presentation and the diagnostic aspect here? You obviously see clear and extended discharge from the wound. If the wound dressing is more moist than usual, and if you examine or press on the wound and find something, that's a good sign. And having a CSF fistula is always prone for infection in terms of arachnoiditis, meningitis, abscesses, and so forth. Patients frequently present with a headache, usually a postural headache, and they have some signs of meningeal irritation, photophobia, nausea, etc. You also, if you do not have that much discharge, you have soft tissue swelling and can easily develop a pseudomeningeal seal. And patients usually have local back pain, but if it's in a rather early postoperative period, they have back pain anyways for a few days. So this is probably not the easiest sign to look out for. Now, usually it's a clinical diagnosis. Some of the papers, they showed a diagnosis within the first 3 weeks after surgery. And if you're not sure about the origin of the liquid, you can do a beta-2 transferrin test in an aspirate, and obviously you need to get some imaging study. Now, I want to focus, just also for the matter of time, want to focus on specific anatomical causes. And in lumbar spinal stenosis cases, in my experience, the key structure here is the cranial lamina. And the most occult tears happen during mobilization of the cranial attachment of the yellow ligament. And with a rongeur or with a dissector, that might create, but especially the rongeur, might create a sharp bony spike on the inner laminar surface, and that dural expansion occludes that tear intraoperatively, and that spike might erode the dura then in the postoperative time. We've talked about breached pedicle screws, so I'm not gonna go into more detail. Now, these are some of the images from Wolfgang Rauschning, and you see the cross section here, and you have basically a lateral aspect of the yellow ligament, which is quite thick, obviously, in spinal stenosis cases. And this here is the cranial lamina, and this here is the area you really should look out for. In this case here, you have the cranial attachment, and this usually goes further up cranially than one would expect. So in order to make sure you really detach everything, you need to go a bit under the lamina, and that's where these occult tears easily happen. Peri or postoperative causes are usually a poor placement of a suction drain, or it had happened that they can dislocate as well, so be sure about that. If you do have a bony spike and intraoperatively everything is fine, and then anesthetist does hypertension or Valsalva type extubations, then the dura might become under more pressure, and the spikes can tear that. Sharp edges from dislocated fractured facet joint fragments can also cause the dura to break. Sometimes if the facet joints or the partially resected facet joints break afterwards, then that can create sharp spikes. And in chronic adhesions and steroid patients and a thinned out dura in these quite elderly patients, frequently that can also cause spontaneous dura leakage here. All right.
Hello. You hear me now? Okay.
Yeah, so we can.
Okay, so we have seen some strategies for direct repair of the CSF leak, but we have another strategies, and these are reducing the subarachnoid fluid pressure or increasing the epidural fluid pressure. So to reduce the subarachnoid fluid pressure, we can use some medications like the acetazolamide. We can adjust the patient position, or we can take some fluid from the subarachnoid space. And to increase the epidural fluid pressure, we can put epidural blood patch, but this, of course, has some potential complications. And probably the best thing is to do a perfect tight fascial closure. So to put the patient on bed rest is probably the easiest way to treat CSF leak. Some of the presenters already commented on that, and I think this is probably the first part of our treatment always. There is clear evidence that putting the patient on vertical position, the pressure of the subarachnoid fluid increases in the lumbar region, and it decreases when laying down. And we have here some studies on dogs that show when you insert a subarachnoid catheter with a sensor in the cervical and lumbar spine, this obviously changes with position. So most papers on guidelines on recommendations for treatment of postoperative CSF leaks include bed rest as one of the first steps, but there is no real consensus in how long must the patient stay in bed. So in a literature review published in World Neurosurgery, 3 days is the recommendation. But in another publication in which they suggest that if you are able to do a good watertight suture, probably there's no need for rest. But in the contrary, if you are not able to do that, probably the patient should stay up to 7 days, up to one week. So in general, patients should be mobilized as soon as they can, because obviously the potential complication of a prolonged bed rest can exceed the advantages for CSF leak treatment. And some authors have found that the healing of the dura probably happens during the first 24 hours. So this is probably the best indication. If a good watertight dura repair has been done, or in the case we have done a MIS procedure, we have seen endoscopy, we have seen tubular micro discectomies or tubular laminectomies. In this case, it's probably bed rest of 24 hours is enough. But in the cases of open surgery, or when we have not been able to achieve a good watertight suture, probably we will use the anti-transdermal position, because this lowers the pressure on the lumbar subarachnoid region even more than the flat position. That for 3 to 5 days, I recommend, or most of the authors recommend. But in these cases, special attention must be paid to the potential complication of pneumocephalus. So be aware of the neurological status of the patient. CSF shunting in the terms of lumbar drain is a strategy that has been used probably for the last 40 or more years for the treatment of CSF leaks. But if you review all the guidelines, like this one 10-step guideline from Luca Papavera that has already been presented also in some previous presentations, they reserve the lumbar drain for the 10 steps, so only in complicated cases, not as one of the first steps. We know that the successful rate of the lumbar drain is very high, around probably 90% of the cases. That lumbar drain is something that surgeons and nurses need to learn about. It can be easily placed even at the bedside. It's a sterile procedure when you put it and also when you remove it to prevent serious or severe infections. And you can set up the system by volume or to drain by pressure. Usually we use by pressure when we are dealing with hydrocephalus, but for spinal CSF leaks, we should drain by volume, as much volume as we can or as the patient tolerates, and we will see something about that. And of course, it's better continuous draining here. So lumbar drain has or should be set up in order to drain as much volume as the patient tolerates, I said. So usually most patients, they have a slight headache that is not a big problem and can be treated with first step painkillers. And if the headache is severe, the collection chamber of the drain must be lifted to avoid overdraining. We can use also volume limiting systems to prevent overdraining and to prevent pneumocephalus. And in the cases that we see that the system is not draining properly, patient must be repositioned and collection chamber must be lower, or we must flush the system. First, flush towards the system, and in the last step towards the patient to avoid, again, complications like increasing the cerebral pressure or even meningitis. Lumbar drain complications can be high, in some series up to 44%, and this includes from slight headaches to severe complications like meningitis or radicular pain. Radicular pain can be caused by mechanical irritation from the catheter, and we can see also some severe complications like this pneumocephalus, tension pneumocephalus, which is here we see the typical radiological sign that is the Mount Fuji sign. It's similar to Mount Fuji in Japan, and this is very severe complication and usually needs surgery and drain the air through a borehole. So one of the best ways to prevent complications from lumbar drains is an adequate training of the nurses, and this includes also patient and family teaching to deal with the drain, because the patient is going to be for some days with it. Nurses need to know how to connect, disconnect the system, to know about overdraining, to prevent it, to evaluate neurological status, check the wound, to see if it's dry or not, and so forth. And usually after 3-5 days, first clamp and re-evaluates the wound, and then if something is not going well, then we can try to open it, or probably we should go for a reoperation. In the case of neurological impairment, an urgent CT, cranial CT, must be ordered to rule out for subdural hematomas or for pneumocephalus. Another very controversial point in the treatment of CSF leaks is the use of antibiotics. We are all worried about the potential complication of meningitis, but if you see in this survey done between USA neurosurgeons, only 11% of them consider prescribing antibiotics, even when using a lumbar drain. And we have a lot of publications about antibiotics, and especially cranial CSF leaks. Many of them have shown that prophylactic antibiotic has no effect on the prevention of meningitis in patients even with skull fractures. And you can think that this has even a higher probability of contamination of the meninges because it's very near, very close to the brain. But on the other hand, we know that CSF leaks is a factor contributing to the risk of perioperative infection. So we have to deal with this dilemma. No? So my home messages would be, and we have to say that most of what we have said is based on experts' opinion. So we don't have really grade 1, grade 2, or even grade 3 good papers, evidence to rely on. So I will recommend to put the patient on bed rest for a maximum of 24 hours in the case of MIS approaches, or we have been able to do a good watertight closure, or a maximum of 5 days if not watertight closure has been done. If there is a still leak, consider reoperation emergency. Reserve the lumbar drain for the most unsolved difficult cases and no more than 5 days. Train the nurses, inform the patient, inform the family, and do a very careful follow-up to avoid these potential complications. And prescribe antibiotics only if you have a lumbar drain for several days, or in some cases you can consider it if you have a CSF leak that primarily is not going to be operated and is going to be treated by only bed rest, but never wait more than a maximum of 5 days. Thank you.
Thank you, Avelino. Let's go for Karsten to show how to the role of large closed CSF collection, symptomatic and asymptomatic. Karsten, please.
Yes, well, thank you. We have 3 minutes left, so I want to keep it very, very short. The extradural collection of CSF usually is of iatrogenic origin. However, the true incidence is often unknown, and many of these are really asymptomatic, which doesn't make it particularly easy to do good science on that. Now, there's a study from the late 80s showing 0.1% in 3,000 laminectomy cases, but the rate obviously is much higher in more complex pathologies with dysraphism and other cord cases and so forth. So very few are traumatic origin, some are congenital, but the vast majority here is iatrogenic. There are different theories about the pathomechanism. Some say the volume of leaked CSF does play a role, and others they postulate a valve mechanism and some form of arachnoid herniation. What sums it up is basically an impairment of dural healing is key to the pathology here. A large defect, a poor soft tissue coverage, scar tissue radiation, infection, steroid agents, elevated CSF pressure, all these play a role in impairing the hearing of the dura, and that leads to subsequent herniation of the rootlets. Patients do have a subcutaneous or subfascial fluid swelling that might increase with Valsalva maneuver. I actually only have seen those two clinical symptoms a few times, but I do have seen a lot of patients that have localized pain, or some even with postural headaches. Some have radicular pain. Usual diagnostics here, and the MRI can be quite impressive. That's one of the cases I found in our collection here, with epifascial, subcutaneous, and subfascial CSF collections. Now, this is really up for discussion about what to do. I think the vast majority of surgeons would say, well, if I diagnose this for some reason, then I need to take care of it. However, there are patients that have been running around with for quite a long time, and if you, for some other reason, do a MRI postoperatively and you discover that there's a significant CSF collection, now there's a reason to go in and do another surgery. This is fine. You can also wait for this, but this really can be discussed. The surgical treatment here is obviously the most definitive way, and then gives the patient, at least reduces the risk of complications such as infections, spinal headaches, recurrence, etc. If you have an earlier postoperative diagnosis, I'd say within the first 3 months, you can drain that, but usually the surgical treatment is something which I personally would prefer here. But just to make it short for reasons of time. Thank you.
I would like to have all the speakers who open the camera just have some questions, to answer some questions. I would like to select some of the questions. It's about, we have one question from Algeria, and when we have a durotomy, we systematically need surgical revision, or how do you decide when to do like an open revision or stay in minimum invasive and try to close the dura? Avelino, what's your idea? When you make a maximum open surgery just to close the dura instead of stay on minimum invasive surgery?
Well, I think usually if you have a small dural tear when you are using tubes, usually if you just put a patch and don't do anything else, it's very uncommon to have a CSF leak outside or to have a big collection, and usually most of the times it solves quite easily. But if you have a very big hole and you are not able to put the roots inside, and you probably in these cases are the one that you should convert into an open. But in my experience, and as most of the presenters have already said, this is quite uncommon when you are doing MIS.
Yeah. I have some questions from Kenneth Cheng. It's about bed rest. What's your opinion in general about bed rest? I usually leave the patient 24 hours. How you do in your routine? What's your idea about bed rest? So, Karsten.
It depends obviously on the size of the defect and my trust in the closure. But 2 days, one day flat, 1 day elevated, up to 3 days, depending on the sufficiency of the closure.
Nestor, what's your experience with that?
I usually in the MIS approach only 24 hours in the bed rest, and the next game the patient can walk in. And the revision only when the symptomatic patient, the medical treatment has failed. And usually if the previous surgery was MIS, maybe the second surgery is MIS or open. When the first procedure is open, always the revision is open surgery.
Okay. Some of you use acetazolamide to reduce CSF production. I don't use. I never use. And intravenous antibiotic when you have CSF leakage, and some of you use intravenous antibiotic during like a lumbar CSF drainage.
Normally, we use it 24 hours. If we have a durotomy, if we have a CSF drain, we use it while the drain is in.
Yeah. It's important every time that we use some like Duragen open near the nerve root and expand, has, like Andrea told us, sometimes they expand and then have this nerve root compression. I usually try to remove all the things that I left over the nerve root. What's your opinion, Michael Wang? How to avoid to do a nerve root compression, trying to close the CSF leakage?
Yeah, it's very difficult. I mean, you kind of see it in our video, right? Because you're distracted by all these nerves in the way, and then usually you're having to drill a lot. And that's the really unfortunate thing for everybody out there. I'm sure they've been in a situation where the dural tear happens at the worst possible time, when you're at the most maximal stenosis and when you haven't really got enough clearance of the bone to do that. So usually, as I think all the videos showed, you try to clear the nerves out of the way, either with a cottonoid or patty or something of that sort, and work around it. Usually trying to go lateral, right? Usually trying to get more facet joint off, but yet not destabilizing. That's a very difficult thing, and I've seen so many cases. I know when I was younger, I was like this too, where you get the dural tear, you just want the case over with. You just want to close it and finish it. But the reality is you've got to kind of keep your wits about you. I think Yoshi was the first to say that, don't panic, right? And that was a phenomenal case he showed at the beginning where they just put, I don't know how many sutures it was, but it's crazy. So I think that's a very good point. I think it's a lot of practice. It's a lot of experience I've had. Oh God, how many hundreds and maybe hundreds and hundreds and hundreds of dural tears. I'm sure, Astrobal, you have less, but still a great many. No. And you just need the experience, right? You need to keep your wits about you.
Yeah, and have you had nerve root irritation by using sealants or by using dural matrix? You try to close the opening dura, and you have a glue, you will have like a dural matrix, and afterwards, after surgery, the patient stay with spinal, with a nerve root irritation. And
yeah,
sometimes
in the U.S., all the products that are on the market technically are safe for that, right? So there shouldn't be irritation. But of course, we do know that when you're using cyanoacrylate, which is what Duraseal is, there is a risk. And of course, there's mechanical, you can stick the nerve to something else and create scar tissue. So I've even seen cases where people sewed the nerve in with the repair, right? So anything can happen. You're absolutely right, Astrobal. But it does become this push-pull. If you remember the trials of trying to prevent scar tissue is healing, right? Fibroblast action. So all of those products that try to limit scar also limit healing. So we really are stuck at this homeostatic plus minus. The stronger something scars or irritates, the better the sealing. And then the weaker it is for that, the weaker the repair. So the classic example is when you use Gore-Tex, like a very synthetic that is very non-reactive, not very biologic. It doesn't irritate the nerves on contact or anything. But on the other hand, to get it to heal to the dura, to scar down is the most difficult. So this is this classic spine problem, right? That it's all push-pull. It's like you want the stuff that doesn't irritate, but you want the stuff that irritates enough or creates enough inflammation so that you do get fibroblast growth. So I think it is it's an opportune area. I'm curious to see what Baxter's coming out with this new. It's like a glue. You just glue and you stick the membrane down, and then hopefully it holds. We'll see. I don't know. So far, we don't have an ideal solution.
Thank you. Thank you. What's the panel idea about use of drains, postoperative drains, even if you have a CSF leakage? During MIS or open surgery, you have incidental durotomy. Have you left some drains in postoperative, like period, 2 or 3 days, or not?
I usually put a drain for 2 days after surgery.
Okay. You leave the drain on gravity? Suction on gravity, yes, or with pressure? Gravity.
Gravity. No pressure.
Okay.
In case with the CSF leak.
Great. Andrea, what's your opinion about that?
I also leave it for 48 hours without any pressure, so there is no dead space and the liquid doesn't impede the dura to heal. So just to take out the dead space. But just for 48 hours, as Yoshi said.
Okay. Carsten, something different?
If possible, I would refrain from using the drain altogether. Sometimes if there's still a lot of oozing, then yes, it helps, and then no suction, gravity only. But if possible, omit the drain.
Okay, thank you. Avelino, there is one question for you. Is how much CSF we can drain in 1 hour or in 1 day? How to measure this? How to have the evaluation of patient symptoms to know that you are draining in a right amount to avoid CSF leakage and not to have any morbidity for the patients?
I think usually for CSF leaks, we don't have to pay much attention to the amount. Some authors say 15, 20 milliliters per hour, something like that. I think you have to drain as much as the patient can tolerate. If the patient has only slight headache and he can easily tolerate that, that's the perfect situation, because obviously you are going to use it for just a few days.
Okay, thank you. So I think that we're gonna wrap up this webinar. Thank you all the participants for being here, and thank you all the faculties. It's always a great pleasure to have you all here. So thank you, and see you again in the next webinar. Thank you all. Thank you. Bye-bye.
Thank you very much.